Hello everybody and welcome to GenQA's Focus On Lymphoma webinar. We are delighted today to have Dr Sheila O'Connor present for us. I'm sure many of you know Dr O'Connor, but for those of you who don't, Sheila has over 40 years experience working in NHS laboratories, and in particular she's over 25 years experience of working in oncology FISH, during which time she has both seen and led in a huge amount of change within the field. And although Sheila is recently retired and enjoying living by the seaside, she remains active in both her role as an education committee member for the British Society of Haematology and as chair of the Haematology Exam Board for the Royal College. So just before I hand you over to Sheila, I'd like to point out that we do have a questions facility within the webinar. So I would like to invite you to ask your questions via this question box. I'll just monitor this during the presentation, and then I can ask Sheila the questions at the end of the session. I should also point out that the session is also being recorded and will later be added to the GenQA YouTube channel. So I think that's everything from me just now. Without further ado, I'll hand you over to Dr Sheila O'Connor for her presentation.
Okay. Thank you, Fiona. It's Sheila O'Connor here. Hopefully you can all hear me clearly. I'd like to thank the organisers at GenQA for inviting me to give this talk. It is a little bit of my swan song, having recently retired, as Fiona said. First of all, I'd like to acknowledge that, like everything else in life, this is very much a team effort. And Sharon Barons and Catherine Turner have been there all, pretty much from the start for developing all these techniques that we're now using for lymphoma FISH. And obviously the whole of the HMDS department and our Haematological Malignancy Research Network provide a lot of the data. And we're part of the Leeds Cancer Centre. I just think I'm going to set a little bit of background first. We tend to think of leukemia as being liquid disease, blood and bone marrow and CSF, and historically handled by the haematology departments. And lymphoma we think of as solid disease with mainly lymph nodes, but any other organ in the body, skin, brain, anything, we can see lymphoma in any site. And these historically have been handled by pathology. You just need to be really aware that there is huge overlap between these entities, and we can see acute leukemias presenting as solid tumours, and we can see lymphomas presenting as liquid disease. So the diagnostic process is really important, and we can't make assumptions just for how the patient presents. Again, just to put it in context, this is a chart showing a normal hemopoiesis in humans, and we're looking at lymphoma arising from mature B and T cells right down at the bottom of this lymphoid-specific maturation part of the pathway. So the lymphomas are, peripheral blood tissue cells. I'm not going to talk today about terminally differentiated plasma cells, so the myelomas, and I'm going to just stick to some mature lymphomas. Not entirely sure where the lymphoid dendritic cells sit in all of this. Dendritic cells are beginning to get much more prominence as being part of the spectrum of hematological malignancy in recent years. So still so much that we need to learn. So for all you bright young scientists out there, there's still loads to do. Very much working within the remit of the WHO classification for lymphoid neoplasms, and this was majorly revised back in 2016. The book didn't get published till 2017, so you'll see the dates used slightly changeably. And the WHO classification is defining disease entities based on their kind of the clinical story, the morphology or the histology, the phenotype, which is really important, as well as genetic abnormalities. Given that we now have over 100 lymphoma types of entities described, we have a long way to go still with describing the molecular pathology behind many of these lymphomas. There are some very important B-cell concepts to understand, and this, understanding these processes will help us to understand what's driving lymphoma. And we always have this search for the putative cell of origin. And we know that, B-cell lymphomas outnumber T cells by a huge margin. And that's probably because of the complexity of what immunoglobulin genes have to do with making very specific antibodies that are best fit. So there's a huge amount of things going on in germinal centers. So mature B cells will enter the germinal center to get antigen specificity and exit. But we know that lymphomas are arising from pre-germinal center cells, such as CLL and mantle cell lymphoma. We know that germinal center lymphomas include diffuse large B, Burkitt, follicular lymphoma. We see diffuse large B in post-germinal cells as well, but cells will go down the plasma cell pathway and end up in myeloma, or memory B cells, and we'll end up with diseases like Waldenstrom's macroglobulinemia. So on trying to understand these processes is part of the pathway towards getting a handle on the genetic mechanisms, which ultimately will give us a pathway to precision medicine. Understanding normal architecture is something I've got a little bit of a bee in my bonnet about. So you really need to know the cells we're looking at. So whether this is peripheral blood or lymph node, and normal tissue architecture is normally really well organized. It's really crisp with really defined areas where different cellular processes are happening. So lymphoma is characterized by alterations in that normal architecture. So the normal architectures are faced by the neoplastic cells. And I'm just showing you 3 examples in this slide. Here's follicular lymphoma. And, it's named that because of these big follicles with very thin margins or mantles around the areas. And there's very little else this could be confused with. There could be follicular hyperplasia, which is reactive. And you just need to be aware that, some extreme reactive states can give you monotypic light chains. Yes, and again, there's a need to be very cautious in diagnosing follicular lymphoma in pediatric cases. This is a mantle cell lymphoma example. This is very monomorphic, small cells, but this immunophenotype, without the immunophenotyping, we don't know what this is. It could be T cell or B cell, and you need to consider marginal zone lymphoma, CLL, as part of your diagnostic pathway. This happens to be a diffuse large B-cell lymphoma, but it's a high-grade lymphoma with high proliferation, so lots of mitotic bodies and lots of apoptosis going on. Again, immunophenotyping is essential because it could be T-cell, but it's more likely to be a diffuse large B-cell lymphoma or a Burkitt lymphoma, or could be follicular lymphoma, large cell type, or blastic mantle. So we need that combination of morphology and phenotyping to put us on the right pathway before genetic testing is done. So how the patients present is really important, and their clinical symptoms to a certain extent determine the kind of sample we receive. This could be an incidental pickup on a full blood count showing a lymphocytosis, but I never believe anything is truly incidental. They must have been a bit unwell to get a full blood count done. Lots of patients with lymphoma present with lymphadenopathy, and they can actually get fast-tracked to surgeons and have a lymph node biopsy done before anybody looks at their blood. So it's really a variable clinical picture. If they've got leukemic, if they've got bone marrow infiltration, patients can become pancytopenic and present with symptoms of anemia or infection, bruising. The lymphoma symptoms are very much driven by the anatomical site. So if it's GI, you'll have gastric symptoms. If it's nasopharyngeal lymphomas, you'll have maybe difficulty swallowing or other symptoms like that. And skin lesions, often rashes or lumps and bumps, which bring patients to doctors pretty fast. And again, we have very specific subtypes being defined, and one of those would be breast implant related and aplastic large cell lymphoma. And so we are seeing increasing numbers of this in recent years. It's impossible to cover everything. It would take all day and you probably wouldn't be very happy. So I'm just going to focus in on a few lymphomas where they have clinically significant gene rearrangements we can detect by FISH. I'm not going to discuss any mutation analysis. I think that needs another webinar, and it needs a suitable expert, which really wouldn't be me. So first of all, marginal zone lymphoma. So marginal zone lymphomas, these are very boringly named because they arise from the margins of B cells around the germinal center. And so these are post-germinal center memory B cells mainly. And these type of cells also live in mucosa-associated lymphoid tissue. So these are in all different organs of the body, which means that we can get marginal lymphomas arising very commonly in the GI tract, mouth, nasopharyngeal cavity, thyroid, breast, lung, so anywhere you think. But it is really an indolent lymphoma. So even the over 80s, which is this purple line here, at 5 years, they're still 65% alive. So it's really slowly paced. So there generally isn't clinical urgency about getting the right diagnosis. And often for these patients, it'll be treating the symptoms. We do know that one of the interesting things with marginal zone is that it's really strongly associated with chronic infections. And our best example will be the H. pylori infections in gastric marginal zone lymphoma. So patients who develop gastric marginal zone lymphomas often have a really long history of chronic gastritis. So patients should always be screened for H. pylori infections and treated. There's a few other associations that we see in ocular or cutaneous. So we're building up a gradual picture of these. And again, it's the chronic switching on of B cells. Genetic accidents will happen. Marginal zone lymphoma will be developed. That can progress further and become a diffuse large B-cell lymphoma. We know that numerical aberrations are really common, gains of 3 and 18 in particular, and we used to test for these maybe 20 years back, but we've stopped a long time ago because it just doesn't alter how the patients get managed or treated, and it doesn't impact on prognosis. The jury's still out on the TP53 in marginal zone lymphomas. Lots of papers say there's no impact. There's a few that say it's got an impact if it's associated with an 8p deletion, so I think it's sort of watch this space. What does have an impact on prognosis will be the gene rearrangements, in particular the MALT1 rearrangements, which are the commonest. And when I say common, in gastric marginal zone lymphomas, we see about 12 to 15% of all cases have a rearrangement, but about 40% of lung. And it's really, MALT rearrangements are very rare in other subgroups of marginal zone lymphoma. And here's an example of a gastric biopsy showing us a rearrangement. So cells are small, tightly packed. So you have to be aware of the size of these cells. And in fact, because they're small cells, a break apart doesn't break the signals apart very far. Again, be aware that you can have a lot of T cell tumor infiltrating cells. And the important thing about this rearrangement is that actually patients do need additional treatment. So the normal treatment would be H. pylori eradication therapy, and then lots of patients will have their lymphomas resolved completely, but this group does need additional treatment. So mantle cell lymphoma. It's not one of the commoner ones. It's about 6% of all of our NHL cases, but mantle cell lymphoma has quite a poor risk. And it may surprise some of you to see this is a survival curves of various lymphomas by their ICD codes. And in the blue line here, we've got diffuse large B. Here's Burkitt lymphoma in this green line. So while more patients die early, they plateau out and you have lots of survivors. The mantle cell, it goes just all the way down. So it's quite a poor lymphoma, despite it being small cell and low proliferation rate. Improved therapies are now stretching the survival, but it's still not great. Again, we have this variable clinical presentation. And patients with splenomegaly who have some laboratories might still diagnose B-cell prolymphocytic leukemia. I would just say they must be tested for the translocation because they're almost always mantle cell lymphomas. And again, we know that some patients, while it's very poor for most patients, there is a subgroup who have really indolent disease, and we've published on this previously. The key feature of mantle cells is that they express cyclin D1 due to the presence of the 1114 translocation. So here's the histology of mantle cells. So again, as I said, monomorphic cells. And cyclin D1 is pretty much just expressed in mantle cell. Most of the other frequent myeloma lymphomas that we see don't express cyclin D1. And there is very good correlation between the aberrant expression of cyclin D1 and the presence of the translocation in mantle cell lymphoma. This wouldn't hold true for other subtypes. Now here's an example of our FISH, and this is tissue, and we always prefer to do the CCND1 break apart on tissue. It's much easier to report an abnormal result, because again, remember, you're going to get some signal dropout. And we prefer the dual fusion, dual color on fresh samples, on our liquid samples where we have whole cells. So here we can see the two fusions in the red and the green. Okay. So we do know that a small proportion of cases that look like mantle cell, present like mantle cell, have no evidence of the cyclin D1 protein and have no evidence of the gene rearrangement. So what do we call these cases, and what's the correct diagnosis? And again, I put a reference in here, which is a very good overview. So a lot of this work's been done by the group in Barcelona, and they've identified that CCND2 rearrangements are the next most frequent genetic event in these cyclin D1 mantle cell lymphomas. So again, there was no commercial probe available, so we designed a probe using MyProbe's system with Cytocell, and we also added in a centromeric 12 probe to pick up trisomy 12, because again, my PhD was all about the CD5 positive 23 negative lymphomas and defining these groups. We know that trisomy 12 occurs fairly frequently. Probe validation, of course, is essential because it's a new product coming into the laboratory, and we just selected samples that had the right phenotype but didn't have any evidence of an 1114. And again, we did a sample swap with the laboratory in Barcelona, and we got appropriate results on all the samples we swapped. So we had some known abnormal slides. So So, and again, it technically works really nicely on tissue. And here are some examples of some of our patients. And we've seen amplification in a couple of cases. Don't entirely know what this means, because amplification as a mechanism of abnormality in lymphomas and in hematological malignancies in general is actually quite rare, unlike the cancers where it's a commoner mechanism. And here's an example of a rearrangement. So again, you can see very clearly split red and green. So this probe works nicely. And our results to date are that we've tested about 250 samples. We're picking up trisomy 12 at the expected frequency. So this matches our historical CLL cases. We've seen 2 cases of amplification, so it is rare. I'm not entirely sure what this means. And we've seen 5 cases of rearrangement, so it is rare. It's only 2%. But it's a really important clinical subgroup given the poor prognosis. And, you know, doing something rare, so test, we have to be, you know, think about our ISO standards requiring, you know, using out-of-date reagents, and how we manage this whole bit when, you know, we might have you know, probes go out of date before we use them. So it's to balance out there. High-grade lymphoma. So we're looking here at and Burkitt lymphomas, the next group, slightly together. So again, it's really important to know that morphology and phenotype alone cannot differentiate between Burkitt lymphoma and particularly high-grade diffuse large B-cell lymphoma. So there will be complete match on the phenotype and on the morphology. So, you know, here's the tissue showing starry sky appearance. But you need to remember, starry sky is just an artifact caused by macrophages kind of chomping up apoptotic bodies. So, you know, this is just something we see when there's high proliferation. Again, the FISH works nicely, and if it is Burkitt, you know, we will see a classic 814 maybe, but we'll also see that in approximately 10% of diffuse large B-cell lymphoma cases. So you kind of have to do a bit more to get an accurate classification of the lymphomas. And this would be the diagnostic pathway we had, and Sharon might recognize some of our slides that I pinched. So again, we need the clinical picture, along with morphology. We need the phenotype, and we have a characteristic germinal center phenotype, very high rate of proliferation. And cases that fit into that category will get all of the FISH testing up front. So we'll do the 4 probes. If there's an isolated MYC rearrangement with the MYC-IG fusion, then it's Burkitt lymphoma. If it's a double or triple hit, and it's, you know, we will continue to check for kappa or lambda if there isn't an IG, because this IG versus non-IG is important. Come to that later. If all the results are normal, then we do look for the 11q. If there's an 11q aberration detected, then it's Burkitt like with an 11q aberration. But if that's normal, we call it diffuse large B-cell lymphoma. The genetics of diffuse large B can be complex. Here are some examples from all different patients. So again, we see BCL2 amplification. That's probably the most common amplification we see. Lots of clusters of fusions here. Again, here we've got multiple copies with multiple fusions in cells. We've got a BCL6 rearrangement here with no extra copies. And here we just have extra copies without rearrangement. Again, we see MYC amplification and MYC-IGH. So we can see all kinds of different patterns in these lymphomas. So they can be, you know, and we don't always fully know what all these mean clinically yet. The question of which probe to use for screening these cases, well, you know, you really need to use both a MYC-IGH, the dual fusion, dual color, as well as a MYC break apart. If you just use one probe, you may miss rare breakpoints or cryptic events. And this is a GenQA requirement, and I believe, you know, we've been recommending this now for a few years, but at the recent round, there's still significant numbers of laboratories just doing one of the tests, just doing a break apart alone, and these laboratories were given a 0.5% deduction if they didn't adequately describe the limitations of this assay. So you really need to stock more than one probe so that you can identify and assess discrepant signal patterns. And I would say, you know, ideally, we probably want to consider other manufacturers as well for these. It's important that your probe is validated for the material that you're actually testing. Some of the manufacturers still validate just on cytogenetic type. preparation, so cell suspensions and MAA. More companies are now designing probes specifically for tissue sections. And the ISO standard does say that you should show that the probe will work on the material actually being tested. Training and competencies were kind of my big thing. I'm kind of put well into education. And I think we do need appropriate cross-disciplinary training for all scientific staff. So if you're pathology, you need some more genomic training. And if you're genomic staff, you need some pathology training. I think it's important as well that our pathologists or hematologists reporting these tests or putting the final report, doing the MDTs, they need to be aware of the limitations of the test. So don't get scared with this. I've just put in a load of random probe maps from different manufacturers. And the really important take-home message is you must know your probe. I don't mind which one you use, but you have to know your probe because they will all map a little bit differently, and you could get different results in different cases. So, know your probe. And to illustrate this, if every lymphoma Burkitt patient had an identical breakpoint, and we see this much more uniformly in CML and in our acute leukemia translocations where there is great uniformity. So if every patient had a breakpoint somewhere down here, then every single test from every manufacturer would give us consistent results. So we would see the break apart with this one, we see the break apart, the rearrangement with this one, and we see the rearrangement with this probe. So, it doesn't matter who you use if the breakpoints are all really standard. Unfortunately, MIC is notorious for having really variant breakpoints. And we do see downstream and upstream. So we see breaks everywhere, and that's why the probes sometimes flank the region of interest by quite a big margin. But, we have seen past breaks down here. And if you have a break downstream like this, then, this probe will be abnormal, this will be normal, and this will be give you an aberrant pattern as illustrated here. So this probe set shows us a clean break apart, red and green. This looks completely normal, and this could still be a MIC IG. It just might be a kappa or lambda. You could completely miss an abnormality with this probe set for this particular patient. And with this aberrant pattern, and this is the probe set, the DACA one that flanks quite closely, but if with this design, you're picking up two fusions and a small red. So you need to be able to see these signals. You might say, well, then which probe is correct? Well, they're all correct. You will only answer the question you ask. So again, think about your probe, know what your probe is doing, and you can still get surprises. I mean, I would say after 25, 26 years of fishing, I was still getting surprises up to the last day. And, just know that we're picking up these downstream and we don't entirely know what they mean. But we think they still deregulate MIC. We don't entirely know what if they're going to completely mimic Burkitt's, should they be treated the same, or what their outcomes will be. So again, a lot of uncertainty and a lot of work still needed. So here's an urgent case to illustrate that. So this is a young adult, very unwell. It came in as a query acute leukemia, and the bone marrow showed us these big, bad, bubbly blue cells with lots of vacuoles. This could be acute leukemia. It could be Burkitt. So phenotyping is essential. You can see the marrow is heavily infiltrated with or starry sky appearance. So phenotyping shows that these are actually mature B cells with germinal center phenotypes. So we've excluded acute leukemia, and the working diagnosis is a high-grade lymphoma, probable Burkitt's. Again, morphology and phenotype cannot distinguish, so FISH is essential. So for this patient, we actually had a triple hit. So there's a MIC rearrangement, and this was one of the bedside marrow smears, so it was a little bit degraded, a little bit fuzzy, but we can still see the rearrangement. There's a Bcell2 rearrangement, so red and or green are split. MIC IGH is ambiguous. We've got some cells with single fusions, but a lot of extra signals, so we're not entirely sure. Bcell6 rearranged, and because it's a fresh sample, we could do TP53, which is also deleted. So up until fairly recently, we would have called all double and triple hit poor risk, but now is a really poor risk. So a recent paper from the Lunenburg Lymphoma Biomarker Consortium, and again, Sharon's a co-author on this paper, and she led all of the work in Leeds on this. But it's really quite clearly demonstrated, and here's our overall survival, that it's only when MIC is rearranged with an immunoglobulin gene, either IGH, kappa, or lambda, that the prognosis is poor. So if you've got a triple hit and it's not in immunoglobulins, you're just sitting in amongst the main pack. So really, we've now refined this prognostication category a little bit more. And it does mean you need to do that one extra step with your probes. Again, this was a custom probe from the MyProbes project. Sharon led on the design and validation for all of this work. And it's a 3-color break apart fusion probe set with MIC Kappa Lambda. Okay, it works really nicely. Here's an example of MIC Lambda, which fortunately is much commoner than MIC Kappa, because I do think red-green fusions are visually much easier to see. I find the red-blue a little bit trickier, but maybe that's just me with my dodgy eyesight after years of fishing. But anyway, it's a probe that works nicely and should be used if it's not an IGH partner. Okay, Burkitt lymphoma. So Burkitt lymphoma has been identified actually for quite a long time ago. Back in 1887, there were the first reports. But it was Dennis Burkitt who put it on the map by the description from his work in Africa of children with the isolated jaw tumors. He is Irish. I put a little Irish flag in there to remind you, because I don't mind to be called British or from the United Kingdom, but not English. And it is Burkitt lymphoma is an aggressive large cell lymphoma, and we consider 3 forms: endemic, African type, and this has got a really strong association with malaria. So again, that chronic drive and EBV infections. You get these drivers causing the B cells to proliferate. We see sporadic forms in Europe, but now we're increasingly seeing, we see a lot of immunodeficiency related as well, mainly with HIV, but any immunodeficiency can give rise to this. Immunodeficiency, if the patient's well controlled on antiretroviral therapy, then the rates of lymphomas are actually going down for this group, but good control of the HIV is really essential. Clinically urgent because it's a very fast-paced disease. And again, it's this very simple genetic profile. There's very little else wrong with the sample. But occasionally we've seen cases that might have trisomy 3 or trisomy 18, but that won't alter the diagnosis if everything else fits. The reason we want to treat fast is that the aim is to cure. So this is, again, our HMON data showing that about 60% of all patients plateau out and are probably cured from their disease. So we want to pick these out. We know that the picture for pediatric cases is even better, with more than 90% surviving using intensive multi-agent therapy. But the picture in endemic Burkitt is still really poor, that the majority of African children with Burkitt lymphoma will still die of their disease just because they don't have access to the chemotherapy, which is really quite sad still. And really, it's identifying patients who are fit enough to survive treatment that we need to pull out. So patients who are frail will get lesser treatment, and it's more controlling the disease or more a palliative approach. And here's, again, another clinically urgent diagnosis. And this is a teenage boy who's acutely unwell with large abdominal mass. Despite a massive abdominal mass, this sent us a small cluster of neck lymph nodes. 3 of these nodes were completely normal nodes. And just one of them, this one here circled in the yellow, is a high-grade lymphoma. You can see how dense this is. It's uniformly replaced. Normal architecture is effaced. And on the immunos, we can see this very high rate of proliferation. This is essentially holding the slide up to the window test. And they're B cells. And again, I'm illustrating with this case because mainly because when you have a normal tissue and abnormal tissue in the same section, it's really important that we know where we're looking. You have to assess the H&E before you do and report your fish. So if we just, this is quite a large area down the microscope, if we report it from there, we get a completely normal result, which can miss a critical diagnosis. So we have to make sure, again, that the staff training is adequate or the communication is adequate to make sure that the fish is reported from this abnormal lymph node, where clearly we can see the rearrangement. Okay, so this is an example of Burkitt lymphoma. So the 11q23 probe, again, Sharon led on the design and implementation of this probe. This is to identify cases with the 11q aberration. So the probes were designed based on the work from the Barcelona group, and initially it was all done by array. And the samples for the validation were selected based on the gene expression profile. And 4 out of 5 of those cases did give an aberrant, the 11q aberrant pattern. So it seems to work well. And again, there was the slide swap over going on. And so the abnormal slides all gave the appropriate abnormal pattern. Again, here's the FISH. It works quite nicely. And we're looking for the loss of a blue signal and the gain of a green signal with this assay. This is an example of an abnormal case. And the trick with reporting this is to, when you see the 2 green signals generally close together, there's often a loss of the blue one. But, you know, the malignant cells, they do what they like and place their signals where they like. But it does work. My opinion, it is slightly challenging still to score. And it does take a little bit of practice. And I think that's always true for any deletion type assays on tissue sections. So you have to consider the cut-through artifact, and is this loss genuine? But it's really seeing the loss and the gain very close together increases your confidence. What we don't know yet, because this is still a provisional entity, is what's the clinical significance of this? Do they require intensive treatment? How well will they respond to treatment? You know, do we find 11q aberrations in other types of lymphoma? You know, can you get a double hit with an 11q? Lots of questions still to be answered as we gather more and more abnormal cases. So overall, for the diffuse large B high-grade lymphoma Burkitt group, practical recommendations are that you should test all cases with MYC, whatever subclassification they have. And you know, you might end up doing some blastic mantle cells in here because there will be some overlap in the initial diagnosis of some of these cases. You know, you have to consider the immunoglobulin partner is a partner versus non-Ig, because this now really has a significance for the prognosis for the patient. And you know, what I call the fuzzy zone, there's always cases that don't quite fit. And we might end up doing more testing on some of these just to help us to work out what a very rare case, individual case is. So 95% of our cases will be fairly straightforward, but there will always be the odd 1 or 2 that don't fit. Okay, Aplastic large cell lymphoma. So this is a T-cell null. So this is the last category of lymphoma I want to talk about. Anaplastic large cell lymphoma, it is a non-Hodgkin's lymphoma, but it's involved in aberrant T cells or null cells. And null lymphocytes makes it a little bit tricky to diagnose sometimes, because by null, they're not expressing many markers. There's not much in the phenotype to pick out. And they can actually look like carcinomas sometimes. So these are classified into 4 subgroups, and they're characterized by strong CD30 membrane expression. And most cases will express some T-cell markers and will have T-cell clonality, but some of them don't have any evidence of T-cell clonality and will have absolutely minimal T-cell phenotypes. And we see these lymphomas in 20%. It's one of the commonest of the childhood lymphomas, and about 3% of adults. And it's the primary systemic anaplastic large cell lymphomas that are clinically aggressive and require treatment, often urgently. So what the cases and these are further subdivided into ALK positive or ALK negative groups. So it's the primary cutaneous localized disease that requires minimal treatment, and the special subtypes are anaplastic large cell lymphoma with breast implant. So with breast implants, this often requires surgery to remove the implant. And so for any case we've tested, we haven't, they've all been fairly standard without any increase in the adverse cytogenetics. For us in hematology, historically, we've not done ALK-FISH testing very much, mainly because the ALK protein is strongly expressed. And the association between the protein expression and the gene rearrangement is really strong. But you need to be aware that doesn't hold true for lung cancer. Not sure about other cancers, but historically we've just not done the FISH testing because we have the antibody test. That may change in the future, we shall see. And again, our morphology is quite distinctive compared to diffuse large B-cell or high-grade lymphomas. And we have what we call these hallmark cells, which are like horseshoe-shaped cells, and they've got abundant cytoplasm. They're really big. But there will be a really admixture of reactive T and B cells in the background. So again, reporting by FISH can be a little bit challenging when we can't see the morphology clearly. It's ALK negative anaplastic large cell lymphomas I want to talk about because the ALK positive cases have a good outcome. So this is this black hashed line. So just here, so ALK negative patients have an adverse outcome. But work done in the last few years by the Mayo Clinic group, so Andrew Feldman and company, they have further identified additional abnormalities which we see in the ALK negative setting. I don't think there's been any crossover cases identified yet, but there almost certainly will be. And basically, TP63 rearrangements are bad. So here's the green line. And you can see that is really steep fall off, and there's no survivors after a few years. But the DUSP22-IRF4 is good. So having this rearrangement actually is an identical prognosis to ALK positive anaplastic large cell lymphoma. So clinically, we want to identify these because we don't want to overtreat patients with the DUSP22, and we might want to consider more aggressive treatment for the TP63 patients, even though, as I said, these are very rare and it'll be hard to get a cohort big enough to test. Again, we have the situation of no commercial probes available, so we designed probes using the MyProbes cytocell system and based on the Feldman paper. And we went for break aparts for the two probes. And again, we have to go through all of the validation. And we did receive known abnormal cases from the Mayo Clinic group. It did take us 6 months to get these because of the legislation around getting pathological material from the country. We might have problems in the future getting material from Europe now that we're no longer in the EU. So it's just a word of warning if you're needing to do some collaborative work with other countries. So here's our design probe for the DUSP22-IRF probe map. And initially we tried to develop a 3-color break apart so that we could distinguish if it was a DUSP22 or an IRF4. This just didn't pan out. It just, cytocell group tried everything to get it to work. There was just too much crossover, and it was just too small. And they're only 40 kb apart. And really what's important to note is that this rearrangement is identical to the IRF4 rearrangement in our diffuse large B-cell lymphoma with an IRF4 rearrangement disease category. And it seems that historically, and I've trawled through every paper about the B and the T-cell diseases, and it looks like the B-cell community just decided to call the probe the region IRF4, and the T-cell community just decided to call it DUSP22. As far as I can tell, it appears to be the same rearrangement in all the cases. And again, in the diffuse large B-cell setting, it's a good risk group to be in if you've got an IRF4 rearrangement. TP63 was technically more straightforward to design, fairly simple break apart, spanning the TP63. Again, just a case to illustrate the use of this probe, and so all the validation finally all came together. So this is a clinically urgent case that we saw a little while back, a 43-year-old man. He presented unwell to the GP. He had lymphadenopathy, he did have a skin rash. This turned out to be completely unrelated to his lymphoma, so a bit of a red herring, pardon the pun. He had no known comorbidities, but he's now really, really sick. I mean, you can actually tell from his blood film that he's probably heading into renal failure with all these burst cells and acanthocytes. But he has these very abnormal, very large cells in his peripheral blood, as well as really toxic neutrophils. He did have a lymph node biopsy, and again, we are seeing these hallmark cells in this mixed cellular background. So the morphology and the phenotype for this patient completely fitted for this being an anaplastic large cell lymphoma, but it was ALK negative. So we did need to do the additional FISH tests for this patient. So here's his result for the DUSP22, and this is the tissue biopsy, and this is his blood. So there's no rearrangement, but there are extra copies. Again, this is easier to count up in the peripheral blood because these are whole cells, so no rearrangement here. And this is his TP63. This is the tissue biopsy and this is the blood. So we're seeing the rearrangement in these abnormal cells in both samples. So this gentleman does have a TP63 rearrangement. This puts him into a very porous category. And unfortunately, this patient died very shortly after diagnosis. So it really is a group that we want to try and identify as early as we can and make sure they get intensive treatment. Just now going to switch tack a little bit and talk about some pitfalls in FISH. So again, the quality of the processing is absolutely essential. You can't speed it up. You can't rush this stage, no matter how urgent the sample is. You know, you might like your steak well done, but you know, if tissue is on the rare side, the middle part here, which is all pale, that's just had a complete cellular meltdown. You know, FISH will fail on this, and this tissue will continue to degrade in the wax block. So high quality tissue processing, absolutely essential for all molecular testing. We always get difficult samples, and Burkitt lymphoma is notorious for this. And it's to do with the high rate of proliferation and cell turnover causes cut-off of the blood supply, so you get localized necrosis. So here on the top row, we have a nice quality sample where we end up getting really crisp, nice FISH, showing a MIC rearrangement. This was the second attempt at a sample of bone marrow from this patient. It was gel-like. It was really horrible. And you can see all this pink cellular mush, and here in the trophine, all of this pink it's just completely dead cells. It's completely necrotic. But we can still salvage FISH. We might have to cut out any pre-treatments because pre-treatments will be the final death knell for these cells. So you might just fix your cells and put the probe straight on. But you know, you have to try. This is as good as it's going to get for some of these patients. So we really want to try and make that diagnosis. Sometimes we get absolutely tiny biopsies. So this is a little needle core from a liver. This is a HIV positive patient with Burkitt lymphoma. So all of this pink, most of the core actually consists of liver, normal liver, and just this tiny tip is lymphoma. We actually managed to diagnose a high-grade lymphoma on this, even though it looks horrid. And you can see on your FISH image that there's this clear demarcation with a really high fluorescence on the liver, and the diffuse part is much darker. It's where the blue cells are. And again, we've got a MIC rearrangement. And being HIV positive, there's an association with EBV. So again, we can identify that this is EBV-driven Burkitt lymphoma in an immunocompromised patient. Do you think it's really important that you're aware of the morphology? Are they big cells, small cells? Are they rare or confluent? And you know, again, it comes back to this crossover training. And tissue architecture is essentially lost down the fluorescent microscope, because all lymphocytes kind of look the same. And lymphoma cells tend to be much smaller than cancer cells. The ALK cases, well, this convoluted nuclei and lots of cytoplasm, they can prove challenging to digest and pre-treat sufficiently sometimes. So we think it's the nature of the sample, so just to be aware you might need additional pre-treatment. And if you're doing Hodgkin's lymphoma, which we do, you know, Reed-Sternberg cells can be present at a frequency of 1 in 1,000 in a sample. And you have to know what these look like and where they are, because they're surrounded by lots and lots of normal T and B cells. So if you just count 100 cells, you will get the wrong result. Here I'm showing you the Reed-Sternberg cells identified by CD30, which picks them out clearly. And here's an example from a series I did on composite lymphomas, where the Reed-Sternberg cell has a Bcell2 rearrangement. So again, it comes back to identifying, you know, knowing what cells you're looking at and identifying the correct area of the biopsy to report. To just finally go into a bit of EQA, and just want to reassure you all that we have come a really long way. I started fishing in 1993, back when I was in Addenbrooke's, and these are some images from my lab notebooks when I first came to Leeds. And you know, when I came to Leeds, I was trying to set up the fish, and now I look at these with horror, thinking, we actually reported these? But we've had all these developments in the image capture software with the fluorochromes. You know, back then we had loads of separate little probes, so we had to label ourselves. The capture time would be about 10 seconds. Now we get stressed if it's more than 0.1 of a second. The FISH setup was quite complex. And most importantly, we had no EQA. You know, there were very few diagnostic labs attempting FISH for lymphoma. So, you know, we were on our own. And, you know, that sometimes with hindsight, that looks like a very shaky place to be. Fortunately, we now have EQA, so we run the CQAS, now GenQA. So I started having conversations with Ross Hastings back in probably about 2003, 2004. So we had fresh samples running first, the CLLs, mantle cells, and the first pilot for paraffin sections was done in 2014. We just had 17 laboratories, and most of the results were correct. A few laboratories failed. And it always still amuses me to think that one lab didn't report because the cells were touching and their policy meant they didn't report. So I'm thinking, well, this is lymphoma, the cells always touch if it's a tissue section. The most recent EQA, we had 58 laboratories. Just one laboratory didn't get a result, so that's really good. And there were no critical analytical errors, which shows a massive improvement on the laboratory skills and competency. We are still seeing some critical interpretation errors. So again, this is a marked improvement, which shows that ongoing education is needed. And remember that the interpretation, this is the bit of the report that goes to the MDT and the clinician and the patient. So if we're not reporting this correctly, you know, there's scope for errors in how the patient gets diagnosed ultimately and treated. So a way to go still. And, you know, my ongoing quality concerns would always, you know, staff training and competency. You know, how do we assess individual performance? Because we can't have, you know, multiple people all reporting or joint reporting. None of us have those staff resources. Should we as a professional group be developing our own resources and, you know, lead into certification? And by professional, I mean the wider professional body as well as our quality assurance groups. And I'm still concerned that many probes that we do use for clinical purpose and the companies know we're using for diagnostic purpose are still labeled research use only. Getting better with lots more probes labeled IVD, but adding the letters IVD almost certainly increases the price. And given that we're going down a pathway of having lymphoma disease-specific EQAs, then with over 100 subtypes of lymphoma, it might be a bit challenging for in the future. So these are a couple of slides from Melody in the in GenQA office. So again, just check out the website for new pilot schemes and that your enrollment is now open. Here's some of the schemes, and again, as you can see, they're expanding, and you're now getting DNA and suspension of cells for many of these schemes. So again, check the website. And I'm now ready to take any questions. Hopefully I've not gone too over time. And this is me on my last day of fishing, carrying a suitable bottle of wine with a fishing label, thanks to Sharon. Looking very happy, probably because I didn't actually report any fish that day. So ready for questions. And I'll just hand back to Fiona in the chat.
Thank you very much, Sheila. That was brilliant. Really, really interesting. I have a couple of questions in the chat. If anybody else would like to add to the questions in the question box, then please do so. The first one I've got is actually from Rose Hastings asking, Sheila, do you know what percentage of breast implants result in breast implant related lymphoma in later years?
I don't know the figures off the top of my head, and it's complicated because it seems to depend on the kind of implant they had, which has now been discontinued. Okay. And it seems to be quite a long time period from the patients I can remember off the top of my head. It was, you know, we're looking at a few years down the line. It's quite sad when people have had, you know, women have had implants following breast cancer surgery, yeah, and then they go on and have a lymphoma afterwards. So I don't have any detail on the cases.
Yeah, I actually wanted to ask myself, I had a note here to ask how important is it for geneticists to have an understanding of morphology and phenotype, but then you later said that it was vitally important. Do you have any sort of recommendations, any resources for any of our participants that would like to sort of start in teaching themselves, essentially, if it's something that they don't have access to?
We've been having some talks like at national school level and in workforce planning, the kind of skill sets people need. And I just do think that we need these, you know, the accredited scientific practice or expertise, you know, that we should be considering having these short courses where we can, you know, I think there's actually quite a lot of genetics information out there. So I think in hematology, we encourage a lot of our trainees to do many of the, you know, there's a master's in genomics or there's short courses available out there, but we don't always have the same resources for our genomics scientists to learn. I think cancer genomics as a profession, and this is now a distinct group in the National School and the Scientist Training Program, you know, they will be developing these skills. But for a lot of us, I think, you know, if you haven't got the skills, you need this really good communication with your pathologist or your scientist in hematology. And, you know, just be aware that even, if you have a piece of tissue, they might mark the H&E, but quite often when you go back and cut additional sections for fish, these sections get, with the best will in the world, it's very hard to sometimes get the orientation exactly the same. So the section could be flipped and it might be the opposite end of the slide.
Yeah, so it is vital that you get the H&E information before you.
So very good communication and ideally training for young scientists coming through the systems.
Coming through, yeah. I also have a comment here from Sven Hawk saying, are you aware that there is now commercial probes available for the DUSP22 IRF4 break apart and 11Q rearrangements? Perhaps that's something to follow up. And
I mean, at the time we started, there weren't commercial.
Yeah.
We probably don't need to buy any commercial. I'm sure Sharon or Catherine will put me right if they're on the meeting, because we probably have a fair stock of it still.
Yeah.
But yes, most of these are, they become commercially available once
you've put a lot of work in
to do them. But being a specialised lymphoma laboratory, we were kind of early implementers of some of these.
Absolutely, yeah. And another question here, Laura would like to ask Sheila your experience of DL Bcell with IGH CCND1 rearrangement, SOX 11 negative by IHC.
Our experience with SOX 11 is that it's a pretty hopeless antibody, and it is often negative. So we did this on tissue arrays with all kinds of mantle cell cases. So did you say
diffuse large B cell
rearrangement?
So diffuse large B cell with IGH CCND1 rearrangement that is SOX 11 negative by IHC.
Yeah, I mean, that's almost certainly a blastic mantle cell because the morphology will look the same. So if there's we wouldn't worry about it. I don't even think we don't do SOX 11 routinely anymore because for us, it was not a reliable antibody. It was quite weak. What about did that patient have cyclin D1 expression?
I'll see if Laura gets back to us on that. Maybe we could follow that up after. I should have mentioned actually, sorry, if there's any other questions that you would want to follow on with it, then you can feel free to email us at info and we can either answer them or ask Sheila to answer them. In response to that though, Sheila, Laura says yes.
Okay, so that will almost certainly, that'll be a blastic mantle cell. So if you've got cyclin D1 expression, you've got the rearrangement, you've got morphology that looks blastic, blastic mantle cell is the category where I would probably have put that, and SOX 11 was feeble in our hands.
Laura, thanks you very much for that information. And just one last question, I think that's the last one. When you talked earlier about having the sort of at least 2 probe approach, you've got your break apart probes and your dual fusion probes because some can be missed. Do you know roughly how many would be missed if you used a 1 probe type approach?
Oh,
quite a significant number.
I would say it's probably relatively infrequent, but I probably have to go back and do some reanalysis. I don't know whether Nikki Foote, if she's on the call, whether it's something that I know that their labbing guys have done quite a lot of work on.
Maybe we can follow that one up then. I don't see Nikki on the chat or on the list of attendees. So I think if that's everything, as I say, feel free to email us with any more questions that you might have. We can follow them up either ourselves or with Sheila. And I would invite you all to give us some feedback on the webinar that we've just seen today. The webinar has been recorded and it will be available on our YouTube channel. So we will email participants and put it on our Twitter and social media accounts to let you know when this is available. Also, if you subscribe to the YouTube channel, you'll get notifications when the webinars are uploaded. Just to add as well, all participants of the webinar will receive a certificate, and our next Focus On webinar will take place in October, and this will be acquired ISCN for beginners. so very relevant to our audience today. And I can see there's a couple more comments coming in for yourself, Sheila, so I'll be sure to pass them on to you.
Okay, thank you. Yeah,
okay.
I've not found my way back to the chat.
That's fine. They're all very complimentary.
Oh, phew.
Okay, so again, thank you very much, Sheila. We really appreciated that interesting webinar today.
Okay, thank you very much for having me, and I shall now go and back to the seaside.
Go and enjoy the seaside, absolutely. Thank you very much. Bye-bye.